This PowerPoint is going to talk about care in the community. So how did we get to community care? That is our focus now, is providing care for people in the community as much as possible. Deinstitutionalization is what brought this. Years ago, we had large psychiatric hospitals that provided care, long-term care to people, sometimes for multitudes of years, and sometimes they just lived in these places for their entire life. There were abuses with this. Sometimes families would commit a family member who really didn't need institutionalization because of psychiatric reasons. Possibly they had a developmental delay or a temperament issue, and it was much easier than it is today to get someone into an institution. So progression of that closed the large hospitals such as the one in Bartonville, and there were others. There was one in Galesburg, so there were a lot of community large hospitals that were multitudes of them in the state. So they closed those, and they did open some larger facilities, but there were very few of them. And as time has progressed, most of those have closed. We only have 2 large inpatient state institutions for mental health in the state of Illinois. One is up north, one is in Springfield, and we have one down south in Illinois for people who have committed a crime but have been found unfit to stand trial because of their mental condition. So with only those few places for people to go for long-term care, the movement was to bring people into the community, and they would be able to receive all their care from a community-based program. So why did this happen? Some of the reasons I already talked about. There were abuses and people who didn't need to be in those types of situations. It was much easier to send someone to an institution than it is now. And that was the best way we knew how to take care of mental health. We didn't have any medications to treat mental health disorders until 1950. Thorazine was the first drug that was developed in 1950. So prior to that, there was no treatment. So that hasn't been all that long ago in history. So once we found medications, then there were more and more. Haldol came shortly after, then Prozac, and so we have made big steps in finding medications to treat mental health disorders. So that helped move people into the community also. With medication, there was better functioning, and so they were able to be in the community. So mental health, just like medical issues, runs by a public health model. So the levels of prevention, primary prevention, just reducing the incidence of mental disorders by helping people to find ways to cope with their stress. And just diminishing stressors within the community. So these are things like preventative measures, education programs, reaching people who are at risk of developing a mental health issue, children who are stressed, maybe people who need some like a new mother who is young and doesn't have experience, giving her some education, some support. The WIC program is something that gives women who maybe have stress because of lack of funding, and makes sure that they have good nutrition, teaches them about nutrition, teaches them about child care, and by making sure the mother has nutrition and care, we can prevent issues in that child, hopefully. And that's just one example, but there's a lot of different education and social services that do this primary prevention. Secondary prevention is healthcare that is directed at early identification and treatment of disorders. So you'll see this in a lot of settings, including our primary care physicians' offices. We ask those questions of patients. Do you are you feeling down? Are you feeling depressed? Are you having issues with feeling safe in your home? So things that we can do to identify this. A lot of churches have mental health screenings. Sometimes the community has mental health screenings, and looking for identification of depression and anxiety in someone who has not yet sought treatment for that, so that we can get a handle on that and refer them to the place that they need to be prior to them having a real problem with that mental health issue. And finally, there's tertiary prevention, and that's healthcare that's directed towards some of the more severe or chronic illnesses to reduce the effects of them on a person's life. This is kind of the recovery part of this. Healthcare that helps people to live their best life here with this disorder that may not go away. So making sure that they have the right medication, that they have the right treatment, that they have support in the community or from their family, things like that can help them to remain in that recovery mode, even though they continue to have the illness. So take a minute here and think about the resources that you have found in your clinical experiences in mental health. There are many things that you have experienced in that, and then there are things that you've learned about. Treatment options in the outpatient setting. Psychiatrists can be found as private, or they can be found in a community mental health setting. A therapist. Primary care physicians do a lot of mental health care. They are not specialists in mental health care, but many of them manage people with a simple depression, anxiety disorders, but they can always refer someone to a psychiatrist if there's more complications with medication management or with disease management. The psychiatrist is actually the expert in that, but the primary care physician is a very close partner in making sure that people continue with their mental health care. The Community Mental Health Center, which encompasses the psychiatrist, the therapist, social workers, case managers, all different kinds of treatment that will help people. The Assertive Community Treatment, the ACT program, those are case managers who go out into the community with individual patients and they have a caseload, and they make sure that these people are seeing their physician, going to appointments. They may take them to the appointments if they don't have a way to get there. They may make sure that they have the things they need, that they have food in their house, that they have their medications set up, that they're taking them. So they're just kind of a partner in making sure that they continue to stay well and be able to live on their own in the community. Partial hospitalization. Some people got to go and see partial hospitalization in your clinical. This is for people who need more than just seeing a therapist on an outpatient basis, but they don't need to be in a hospital. So they're not suicidal, they don't have any major substance abuse issues, they're not manic, probably someone with an antisocial personality probably wouldn't fit there very well either, but it is a good way for someone to see a psychiatrist and get their medications either ordered or reviewed, and then to get therapy for usually about 2 weeks is the length of the program. And they come, it's a day program, so they come in the morning, and then after treatment that day they go home, and they come back the next day, and hopefully they see progression, that they're doing better in their home situation as they're continuing this program. So they kind of get to try out what they've learned, the skills, the stress management, the coping skills that they're learning as when they go home, and then they can come back the next day and kind of talk about how that's gone. Emergency response comes from Unity Place. Those are people who are trained in community response to people who are in crisis. They will evaluate the situation and either help the person deal with whatever that situation is, or maybe bring them to the hospital if they need to be. Families can call for help, patients can call for help, and emergency response will come out. Sometimes they will bring people to a hospital that need to come. Sometimes they'll call an ambulance, and an ambulance will bring them. If necessary, the police will accompany them for safety reasons if there is someone who we think might be a danger. Community residences, these go from group homes to mental health nursing homes that provide care long-term for people. And then the home health care nurse may come and visit people who meet the criteria for home health care and who have a mental health diagnosis. I am not sure about OSF's home health care program, but I know at Methodist they have designated mental health nurses who also do whatever type of medical care that the person needs, but they also provide mental health services and monitoring of medication and conditions. So a special population for the mentally ill are the homeless. So the statistics are that a great number of homeless have a mental health issue. I think that kind of makes sense. While people who have mental health issues may be more likely to be homeless, people who are homeless who didn't start out with a mental health diagnosis are going to have a lot of stress. They may be depressed, so there is a lot of issues that people have who are homeless, even if they don't have a diagnosed mental health disorder. Things that factor into this, people with like a psychotic illness may not really trust people. They may not want to live in a group home. especially if they're not being compliant with their medication, so they may end up being homeless. Financial issues, the lack of housing options for them. So there's a lot of factors here that contribute to this. Sometimes it's substance abuse. They're using drugs or alcohol to cope with their illness, and that is contributing to them being homeless also. There are resources for the homeless. We have shelters. Some of the social service agencies in Peoria do help with finding people placement somewhere in homes. The homeless shelters also offer mental health services and social work services for people to try to get them back into a homed environment. Some larger cities have like a mobile outreach where people go out into the community to the homeless population and bring them food and information about how they can go to a shelter and try to talk people into coming in and maybe seeing a provider, maybe coming in for meals, and then finding some place to be housed and rather than living on the street. And also sometimes there are street clinics in larger cities where there's a walk-in where people can just go in to get help with a lot of their social issues and their mental health issues.